I'm delighted to introduce Zena Moore. She's Chair in Nursing, the Royal College of Surgeons in Ireland, and she's going to be talking to us about assessing sub-epidermal moisture as a predictor of pressure damage. So thanks for being here, Zena, and over to you. Thank you.
Thanks very much, Sarah. Are you sharing my slides, Dawn?
We can do, Zena. Yeah, not a problem at all. I think Kerry might have them open for you.
I do have your presentation open, Zena. You will need to shout next slide at me.
Perfect, no problem.
Every time you want to swap over, but bear with me for 1 second while I share.
Thanks a million.
Okay, are you seeing that? Is that?
Yeah, that's perfect for me. I hope it's okay for everybody else.
Yes,
Yeah?
it is. Thank you.
Great, great. So it's great to be here. We've just had our own stop pressure ulcer session downstairs and it was very, very well received. So a hugely important subject here for us. So as I said, I'm going to speak about assessing sub-epidermal moisture as a predictor of pressure damage. Next slide, please. So just a conflict of interest statement that the School of Nursing and Midwifery here at RCSI has a research collaboration with Broome Biometrics. Next slide, please. So what I thought we would cover today is what is our contemporary understanding of pressure ulcer development? Why is early detection of tissue damage actually beneficial? What is SEM assessment and what does it tell us? And then I'll present the results of a systematic review exploring the impact of SEM assessment in practice. Next slide, please. So, thinking about the contemporary understanding of pressure ulcer development, our colleagues Amit Geffen and team have done a huge amount of work in helping us to understand how it is that patients actually develop pressure ulcers when they are exposed to pressure and shear. So what we understand is that sustained deformations of the skin and deeper tissues have to be present in order to cause the initial cell death and tissue damage. And that's important for us when we're thinking about risk assessment. So excess internal or prolonged tissue exposure to stressors and strains damages the cell structures, for example, the cytoskeleton or the plasma membrane. And these stressors and strains also reduce blood perfusion, impairing lymphatic function, thereby affecting transport in the interstitial spaces. The cell death then triggers an inflammatory response, and this causes an inflammatory oedema which further increases the mechanical loads on the cells and tissues due to a rise in the interstitial pressure levels. So next slide, please. So it's really like a catch-22 situation. So we can see from the image from Amit that first of all, we can detect deformation damage. That's direct. That will result in an inflammatory damage, which then will cause an ischemic damage, and that's when we run into trouble. But when we look at the image on your right-hand side, we can see how the cumulative damage occurs over time. But our direct deformation damage is the first issue, which then, as I said, causes the inflammatory damage, causes the ischemic damage, which happens over time. So what he's really telling us is that if we could understand quickly how our patients are responding to the pressure and shear that they're exposed to, that would enable us a much better opportunity of reversing the processes before it's too late. So next slide, please. And the key thing is that the cell damage may be visible on a microscopic level within just a few minutes, but it actually may take hours of sustained loading for the damage to become clinically visible. So if you were able to detect in me really quickly that I'm actually showing changes microscopically that indicate that I'm not tolerating the pressure and shear, and you were able to do something about that, that would be really useful to us. And it's important for us to remember as well that internal strains and stresses adjacent to the bony prominences are much higher than those near the surface. But of course you and I can't see them because this is much, much deeper. And these can cause damage in the deeper tissue before the superficial tissue, and crucially, before the damage is visible to the naked eye. Because in day-to-day practice in general, you and I are using our naked eye to be able to assess responses in the patient as a result of them being exposed to pressure and shear. And clearly that's challenging for us because a lot of processes will be going on that you and I are unaware of before we can actually see manifestations of it on the tissue. Next slide, please. So then it leads us to really thinking, okay, let's bear in mind what Amit and all of our bioengineering colleagues have helped us in terms of their work explaining to us what actually happens when somebody is exposed to pressure and shear. So understanding that, then I ask myself, well, why then is early detection of tissue damage beneficial? So next slide, please. So when we look at this diagram here, what I want you to focus on is the lower red line, which is looking at those inflammatory processes that Amit was talking about. And if we go into the above that lower red line, where we can see that damage can occur 3 to 10 days earlier than what is actually manifested on the tissue. So the top layer that we're looking at, the very top line there, that is when there is actual damage that you and I can see with our naked eye. But see all of the cascade of events that are occurring beneath that. And if we were able to understand that, we would be able to intervene before the patient was developing an actual visual problem. And that's the reason why it is important to us. Next slide, please. And it's important because it enables early intervention when the damage is still microscopic and reversible, and therefore it has the potential to prevent further aggregation of healthy surrounding tissue. It arises by avoiding that causation of the problem and stopping the knock-on effect of inflammation that we saw in that image earlier on, especially when the rapid pressure ulceration pathway of deformation is in place. And an example of how this is really important is, for example, you or I could walk into the operating room for a procedure, but that procedure could be quite lengthy, and you and I actually may have issues in relation to our responses to pressure and shear, which occurred during the operating procedure, but would be undetected until changes in the tissue are visualized later on, perhaps on the clinical ward. Now imagine if you and I were able to know that on discharge of the patient from the operating room. Because if you reflect on risk assessment within the patients undergoing surgery, we tend to risk assess them before the operation and after the operation, but the issues are arising during the operation, and the person before and after the operation are different to the person they were during the surgery. Now imagine if I'm coming out of the operating room after, for example, having a fractured hip repaired, and I have some early damage in my left heel because it was my right hip that was being repaired. If you knew that straight away, you would be able to offload my left heel immediately and avoid this continuous cascade of this catch-22 situation that's arising. And the other thing that's important is that when the slow ischemic reperfusion related mechanism is undergoing, the cell death can be avoided when the problem is identified before the cell reaches the death threshold. Because once it's reached the death threshold, you know that it has no power of regeneration. It has to heal by repair, and we see that in its manifestation as a wound that you have to manage. So next slide, please. So just synthesizing why it is important is because as humans, we can't with our naked eye see what's happening underneath the patient's skin. But there are technologies which enable us to see that, and by doing that, they give us a window into the problem much, much earlier than we as humans have the physical capacity to do without use of certain technologies. So next slide, please. So what is SEM assessment and what does it tell us? So SEM is one such technology. There are other technologies like ultrasound, but SEM is one technology that we at RCSI have done quite a lot of research work into. But let's explore what it is and what does it tell us. So next slide, please. So sub-epidermal moisture, it's a biophysical marker, and it's a product of the leak of plasma after the inflammation process increases the local vasculature permeability. So just reflect back to remember when you were learning about wound healing when you were a student, or when you were doing your postgraduate diploma in wound healing and tissue repair, we learned about the inflammatory process as being the first step. And we know that inflammation causes this leakage of the because of this local vascular permeability. It's important to remember that sub-epidermal moisture is different from epidermal hydration, which is another biophysical marker for superficial damage that expresses the water content of the epidermis. And this epidermal hydration, which is totally different to SEM, is influenced by microclimate parameters such as temperature and moisture, like feces, urine and sweat. However, SEM is different and it is related to the deeper layers, and it's not influenced by environmental changes. However, it is directly related to inflammation. And when the tissue damage progresses to a greater number of cells, the inflammation markers increase along with the plasma leakage through the blood vessels. So, SEM that starts as a microscopic oedema, if you and I were unaware it was there and did nothing about it, it grows to a macroscopic scale and becomes detectable on imaging examinations and then later with the naked eye. Next slide, please. So it increases after tissue damage and it changes the electrical capacitance of the tissues even when the oedema is still at microscopic levels. And this can be measured using surface electrical biocapacitance devices. And the biocapacitance is an electrical property of tissues that varies with the amount of interstitial moisture content. The greater the interstitial moisture, the higher the biocapacitance of the tissue. And this biocapacitance is then interpreted by the SEM scanner. So it sends a signal out to the tissues. The more of that signal that is held onto by the tissues, the higher the reading will be on the SEM scanner, indicating that there is a greater amount of sub-epidermal moisture holding on to the signal within the tissues, telling us there is a potential problem. Next slide, please. So we measure it using the SEM scanner, and it's calculated as the difference between the lowest and the highest readings after the scans are taken in each anatomical location. So the delta is the difference between the highest and lowest reading for that individual patient in that anatomical area. It's recommended to take 4 scans for the heel and 6 scans on the sacrum, and a delta of 0.6 is considered to be abnormal. And the reason why I stress the importance of it about being the individual's reading is that my baseline readings, my raw readings, might actually be higher than yours, but I will not have an abnormal delta for me personally unless I have evidence of inflammation. So that delta is really, really important. And people often ask, well, what about the patient in ICU who's got systemic oedema? Well, their baseline readings, like the 4 scans that you take, will be different than yours, but they won't have an abnormal delta unless there is evidence of inflammation. So next slide, please. So let's look at some of the research and see what is it telling us. So here's a study that was done by a colleague of ours, Gillian O'Brien, and she looked at the relationship between nurses' visual assessment of the skin and sub-epidermal moisture assessment. The study was done in acute care in at-risk adults. The data were collected daily for 20 days. 62% are female with a mean age of 74.7. 34% of them developed signs of early pressure ulcer damage. The mean number of days for nurses to detect this was 5, and the mean number of days for SEM to detect this was 1.1. So SEM assessment identified the early damage 3.9 days earlier than nurses' assessment, indicating that in this case, no interventions over and above usual care were offered. It was an observational study. But what we noticed was we could detect the changes much earlier using SEM assessment than visual skin assessment. So next slide, please. And here's the role of SEM assessment versus traditional risk assessment in the prediction of risk among adults undergoing surgery. Acute care, 228 patients, data collected daily for 3 days, 55.8% are male with a mean age of 85.6. 53% underwent orthopaedic surgery and 47 general surgery, with a mean duration of surgery of 88.4. Using SEM assessment, we identified 51% of them showing evidence of pressure injury damage, whereas with visual skin assessment, it was only 3%. And what I'm showing you in the table here, you can see that on day 1, there was 98% of them had evidence of abnormal deltas. Now, they're not all staying in hospital for the whole 3 days, but even those who stayed in hospital for 3 days had 94% of them were still showing evidence of abnormal SEM deltas, indicating that inflammatory processes that had occurred during the surgery were persisting post-operatively. Now, they didn't have visual evidence of pressure ulcers, but it's still important for us, because if they have a problem in the heel, right heel, left heel, sacrum, and we're not offloading them, we are causing them to be exposed to sustained pressure and shear over an area which is already showing that it cannot tolerate the pressure and shear that it was exposed to during surgery. So next slide, please. Looking at risk factors and risk screening in older persons. So it was 150 patients in an older person setting, data collected daily for 20 days using a movement sensor, sub-epidermal moisture and visual skin assessment. 74% female with a mean age of 84.3. The mean movement score that patients were making was 121 moves per hour. Now, what you can see here at the top box plot, if you look over to your right hand side, on the left box plot is healthy volunteers and the right box plot are older adults. And some people, you can see that you and I make similar types of movements during the night time. Whereas the older adults, some are not moving at all, as you can see, and some are moving a huge amount, but there's a great variability in their movement. Now, what's interesting is that when they looked at the visual skin assessment, 12.7% of the patients developed evidence of pressure ulcers, but 6.7% of them occurred in what we would call low movers, and you'd say, no surprise there, Zena. However, 6% also occurred among the high movers. Now, the reason why this is important is because just counting movements is not going to help you and I to know whether the type of movement the patient is making is protective or not. And similar, even though the sub-epidermal moisture assessment identifies a lot more patients with damage, but there's still the similar distribution between those who are low movers, 40%, and those who are high movers, 38.7%. So it is telling us something very, very important, that we need to assess patients who are making abnormal, unprotected movements, because they would be exposed to friction and shear, which we need to address in terms of our algorithms of care. And the bottom box plot on your right hand side is showing the mean difference in time to SEM to detect the pressure ulcer versus visual skin assessment is 6.2 days earlier. So really giving us a window into how well these patients were responding to the pressure and shear and friction that they were exposed to. Next slide, please. So a similar study done by another colleague of ours, Pinar Avsar, in a similar care setting with 53 patients, did exactly the same as Iglesia had done in the previous study, similar profile of patients, similar age group. But it's interesting that 51% were considered to be not at risk or mild risk, according to Braden. Similar mean movements per hour, 110, and we identified that 41% of them were actual low movers. Similar figures you can see here for the pressure ulcer incidence with SEM, 79, with visual skin assessment, 15. Look at the movement, you can see here in the box plot, just the same as Iglesia showed us, so providing further evidence that our older population, some are making absolutely no movements and some are making a huge amount of movements that are not necessarily protective. Because as with Iglesia's study, Pinar found the very same, that problems arose in those who are low movers and high movers, calling us to really reassess what it is that we're doing. So next slide, please. Here's a study that's an ex vivo edema model that was really looking at what happens to the SEM readings when we inject fluid, and we can follow the amount of fluid that we're injecting into the hind leg of pigs to see what happens when we inject the fluid, what happens to the actual SEM readings, and do they follow as you and I would expect. So it was designed to quantify the sensitivity of the SEM scanner. The porcine hind limb heel, there were 10. Phosphate was buffered saline solution delivered to the dermis via an intradermal needle and syringe pump, and the readings were then taken at the injection site and a control site. And as you can see, as the fluid levels injected increased, so too did the SEM deltas, telling us that it's sensitive to this. Next slide, please. And then looking at the relationship between SEM and inflammatory markers, because this is done quite commonly. 53 participants in the ICU, neuro ICU, and the high dependency unit. Study was done by our colleague Natalie McAvoy. The mean age is 58, 72% are female. For baseline and daily for 3 days, she did SEM, visual skin assessment, and she measured interleukin-1 alpha using a sebo tape. She had the right heel, left heel, sacrum, and control. And you can see the SEM readings on your left-hand side and the interleukin-1 alpha readings on your right-hand side. And she also had a healthy volunteer group, which are in the red boxes, and the patients are in the blue boxes. So what you can see across is that, as you would expect, patients have completely different readings to healthy volunteers in both SEM and interleukin-1 alpha. But she found very weak correlations between the SEM delta and the interleukin-1 alpha total protein readings. And what she found is, and her hypothesis is that SEM is measuring localized inflammation at the deeper layers of the tissues, whereas when you're taking a sebo tape reading, you're taking a reading of the systemic inflammatory responses. So one is a localized response. Interleukin-1 alpha is a systemic inflammatory response, and as you can imagine, patients in ICU who are very sick have a lot of circulating inflammatory markers, and that's what the interleukin-1 alpha was showing us. So SEM would be showing us if there's problems in localized areas, where the IL-1 alpha was showing us from a circulatory perspective. Next slide, please. And then looking at the correlation between SEM, epidermal hydration, temperature, pain, and ultrasound, our colleague Hannah Wilson conducted this study. So 60 patients undergoing elective cardiothoracic, orthopedic or general surgery with a mean age of 58, 50% are males, and 96.7 had a general anaesthetic with the mean operating time of 220 minutes. She did, as I said, the measures there, and what you're looking at here are the SEM, the sacrum, the left heel, and the right heel. And on the right box explains. So for a measurement for epidermal hydration, there was no evidence of a correlation with SEM, or a negligible evidence. And what she hypothesizes is that epidermal hydration, as we talked about previously, and SEM are measuring different anatomical structures. One is measuring on the outside and the other is measuring in the deeper layers. For temperature, there's no evidence, or a low positive and negative. And the challenge with temperature and pressure ulcer development is that it's highly variable, sometimes low, indicating a problem, and sometimes high. And it's complex to interpret it because we have the absence of a threshold. For ultrasound, she had a low and moderately positive correlation, and a consistent correlation existed, meaning that you can see similar changes with SEM and ultrasound, but SEM is able to detect it earlier than ultrasound. And for pain, she found no correlation because of a low incidence of reported pain, and post-operative pain in general being a confounding factor. So next slide, please. So what is the significance of an abnormal SEM delta in synthesis here? Is that we know it's a vicious cycle. We know we have to really try to intervene before the manifestation threshold. And we know we have interventions that we can use to do that. So the significance of detecting it is that you actually have to treat it. It's like treating a wound. The patient is showing you evidence of inflammation. We have to attack that inflammation and reverse it. So next slide, please. So the systematic review evidence then, next slide please, is exploring all publications which describe changes in clinical decision making and in the delivery of pressure ulcer care pathways as a result of detecting an abnormally raised SEM. And if you're like me, this is the sort of question you would ask. So knowing what we know about SEM, what difference does it make in practice? What difference does it make to our clinical pathways? And it really was about so what and what next after you and I detect challenges. So next slide, please. So we followed the preferred reporting items for systematic review and meta-analysis. The protocol was pre-registered and we used the PEO mnemonic as follows. The population were adults at risk of developing pressure ulcers. The exposure was assessment using SEM and then implementing skin bundles according to the results of the SEM assessment. And the outcome, primary, was changes in the delivery of pressure ulcer care pathway, and secondary was pressure ulcer incidence, SEM delta, changes in the SEM delta scores, nurse experience and feedback on the use of the SEM scanner and the care pathway. So next slide, please. So we explored 11 databases from inception to 2023. We screened the articles by 2 authors, and then the same process was for the full text articles and data extraction. The data were analysed using a narrative synthesis and a meta-analysis where appropriate, and we used the EBL checklist for quality appraisal, whereupon the studies are assessed based on 4 main steps: the population, data collection, study designs and results. And when you go through these, you score them based on each of these elements. And the score, if the overall validity of this study is greater than or equal to 75%, then this study is considered to be valid. Next slide, please. 10 studies met the inclusion criteria conducted between 2017 and 2022. 3 were pragmatic studies, 1 quantitative quasi-experimental observational, 1 pilot RCT, 1 case study, 1 pilot study, 1 retrospective study, 1 before and after, and 1 descriptive. The majority were conducted in the UK and 1 each in Ireland, Australia and Canada. Most were conducted in hospitals. Long-term care, community and palliative care were also included. The mean sample size is 502 and the mean validity score was for all studies was 87%. Next slide, please. So, the care planning that was implemented included all these elements: the skin bundle, pressure redistributing mattresses, barrier creams, repositioning, patient education, ward-based care and nutritional care plans. Next slide, please. So, what was the impact on practice? 9 out of 10 of the studies reported that a change in clinical practice took place as a result of the SEM assessments. 1 study reported the proportion of time participants received pressure injury prevention. In 7 of the studies, use of the scanner was reported to impact care delivery through the implementation of a guided care plan. And 4 out of 10 of the studies reported the percentage of patients who received changes in care planning, and the mean rate of change was 62.4%. Next slide, please. So what was the nature of the change in practice? So support surface use was reported in 5 out of 10, with a mean increase of 66.6%. Repositioning was reported in 5 out of 10, with a mean increase of 74.6%. And a use of barrier cream was reported in 4 out of 10, with a mean increase of this in 66.2% of cases. Next slide, please. What about the development of a visual pressure ulcer was reported in 10 of the studies. In 3 studies, you can see the references there, the focus was on post-implementation only. And Fletcher and Roper found no pressure ulcer development. And in Uzi, 33.6% of the patients assessed by anatomy showed skin reddening. Next slide, please. So in terms of meta-analysis of 7 out of 10 studies, we could see a pressure ulcer incidence of 1% in the SEM care pathway group, 25% in the usual care group. The odds ratio of pressure ulcer development is 0.36 in favour of the actual SEM pathway group, which indicates a 64% reduction in the odds of developing a pressure ulcer if you use the SEM care pathway group. Next slide, please. looking at developing a SEM pressure ulcer, so in other words, just changes, not just changes, but changes according to our delta. In the control group, there was 77.4% in this one study, and in the experimental group, 47%. So the odds ratio of SEM pressure ulcer was 0.26, indicating a 74% reduction in the risk of developing a SEM PU. Next slide, please. What about the impact on mean SEM deltas? Because it makes sense for us to look at changes in the SEM deltas over time. Because as I said to you, it's an inflammatory process. So if we intervene, we wouldn't expect the inflammation to be here and gone immediately. We would expect it to dissipate over time. So we can see here that the mean difference in the SEM delta is minus 0.49 in favour of the experimental group, showing that when we target the inflammation will start to reduce. Next slide, please. So about nurse feedback was reported in 2 studies, and both noted that the nurse experience and confidence, as you would expect, in using the SEM scanner increased over time. It demonstrated its effectiveness in identifying patients with a deviation of 0.6, which alerted the nurses to take appropriate action. For RAIN, the majority of nurses found that the SEM scanner was easy to use, operate and integrate, and all of them agreed that the data provided to them because of this number was clinically meaningful. Next slide, please. In one study, their staff reported positively to the clarity and user-friendliness of the implemented care pathway. They found it easy to follow and was beneficial. And they also highlighted the importance of addressing concerns about the consistent adherence. So it doesn't just happen by magic, as you well know. We have to adhere to the pathways. And also that staff might need additional equipment or education in order to help to make sure that the pathway would work. So it's not just one single thing. It's a collective, as you know, and a team effort. So next slide, please. So early detection of tissue damage is critical in directing healthcare practitioners to implement timely preventative interventions when the damage is still microscopic and reversible. Treating localized edema as if it were a stage 1 in anatomies that exhibit raised levels of SEM halts the progression of tissue damage before the cells reach the point of death, and therefore prevents the development of a visible PU. The review demonstrated that latencies in providing interventions and diagnosing early stage pressure ulcer damage may be resolved by using SEM assessments that guide anatomy targeted clinical actions. Next slide, please. The majority of the studies that we included in the review were observational, and clearly we do need more robust research in terms of randomised controlled trials to strengthen the findings. Cost considerations were not always considered in the studies, but they are crucial when evaluating implementation of new technologies to show the cost savings that can be made. And the success of any intervention, as you well know, is dependent on the consistent applications of the element, but these must be appropriate to the patient. Clearly, not all patients require the same elements, and that makes randomised controlled trials challenging because, for example, I can happily say to you that I'm not incontinent and neither am I malnourished. So if I were at risk of pressure ulcers, you would not need to be giving me extra nutritional interventions, even though I might really like you to. And that makes randomised controlled trials challenging because not everybody in your intervention group will get exactly the same interventions each and every single time. So it's worthy of bearing in mind when we are designing trials as to how we can address that. Clearly, the more people we have in the studies, the more we will be able to show trends in the actual data. Next slide, please. So the systematic review has provided evidence that implementing SEM assessments in patients at risk of developing pressure ulcers prompts anatomy-specific actions. Furthermore, the subsequent implementation of enhanced and targeted skincare interventions has shown to lead to reductions in pressure ulcer incidence. Next slide, please. Thank you very much.
Thanks, Zena. That was fascinating. There's no specific questions at the moment. I know we've got a follow-on session now, but I'm just interested in when you sort of talked about the systematic review and looked at implementation, maybe a change in pathway or in clinical practice as a result of this. You mentioned things like support surfaces, repositioning, and the use of maybe barrier products. to me, maybe just playing devil's advocate here, but if people are requiring that, are you suggesting then that when people are risk assessed, they are not picking up on those risks, and therefore those interventions aren't in place, but as a result of using the SEM scanner, they realise that that had to be done?
I think that's really what it is, Dawn. Sarah, sorry, is that I'm not suggesting, like, what might happen is that you might decide to change the mattress. I think sometimes mattresses can be a very easy one for us because it's easy to put that on, but in terms of, for example, maybe offloading the heel or increasing the repositioning frequency, that can be a lot more challenging to achieve. And I think that the difference is that instead of thinking that we have this macroscopic assessment of somebody using Braden or Waterloo or whatever, and then thinking that if we keep doing that we're going to have an understanding of that patient's risk. What we have found through our research is that is not so, particularly in the older population, where you find that the mean and standard deviation of their Braden or Waterloo scores doesn't change over time. But clearly none of us are static. And what the SEM scanner enables us to do is to have, just like as if you check my blood pressure now, Sarah, you'd see that it's raised. Because I'm obviously excited doing the presentation here, even though to you I look exactly the same as I did when I started the presentation. And what that would be telling you is Zena's individual responses to the stressors or strains that she's exposed to. And I think we have to move away from this macroscopic way of assessing patients to becoming much more individualised but meaningful. And so if your patient's Braden or Waterloo is not changing, but you can see that there are changes in the SEM deltas and the patient's heel, right heel, left heel, then you can actually intervene more effectively than you might think, because you might be waiting until see some red, but red is too late then. Does that make sense?
Yes,
how people used it because they were prompted to understand. And the value as well, Sarah, is that if the patient was fine, we don't need to change our care plan. And an awful lot of time in Ireland, the Health Information and Quality Authority will come into the older person setting and will say, why is Mrs. So-and-so not on a repositioning schedule? But she doesn't need it.
yeah.
You know what I mean? And we're assessing her carefully, and she's having a good night's sleep, and she's thanking all of us very much for that in the morning when she can do her physio and eat her breakfast and dinner and tea because she feels well. So I think there's a lot of advantages to it in enabling us to be much more personalised, like we do with blood pressure, temperature and all of that.
Yeah, I was going to say that it's that sort of personalised, holistic sort of practice, isn't it? Because I suppose another thing that you had some feedback there about the experience of using this, but was there any suggestion that some clinicians felt that it was maybe replacing things like clinical judgment, or is the danger of maybe us not looking holistically or using clinical judgment because we're going just on a result from a scanner?
Yeah. Well, I think two things are important, is because if you and I were together now and we were assessing our patients, one thing we have to do, we have to look. Do you know what I mean? And that's really, really important. And obviously, as we're looking at the patient and talking to the patient, we're doing our scans over the weight-bearing areas. So in essence, like, you know that danger before, do you remember when somebody would be wearing a compression stocking and nobody would take it off to check the heel? Well, clearly, if you and I know we have to take a SEM reading from the heel, we're going to take it off. And as taking it off, we're going to see a lot more than we might do in the absence of doing that. And I suppose if you think about it, like, why is it that people do actually record blood pressure a lot more frequently than they might do skin assessment? Because somebody's going to ask Sarah what's Zena's blood pressure. Now, if we have figures which can give us a clear indication, and we're confident because a lot of work has been done to show us that this is accurate, and you'll say, well, how are Zena's heels today? And I'll say the readings are okay. Well, I know you're going to ask me, and I have absolute evidence, because before somebody might say all pressure areas checked. And then you ask, well, did you actually check all of the areas? You didn't. Whereas we can be a lot more objective about what we're doing and really understanding the patient's individuality.
That's brilliant. Thank you so much. That was absolutely fascinating, and I really appreciate the time you've taken today to join us. So thanks very much, Zena.
Okay.
Thank
Take care.
you.